Hi folks, welcome to my channel, The Average Dermadoc. Let's begin the show. Antimalarials used in DVL are 4-aminoquinolines that are HCQ and CQ. Coming to classification of antimalarials, as we all have already seen, 4-aminoquinolines HCQ, CQ, 8-aminoquinolines primaquine and tafenoquine, cinchona alkaloid, quinine and quinidine. This quinine is an alkaloid extracted from the bark of the tree cinchona. As this plant has antipyretic effect, it is also called as the fever tree. Acridines, quinacrine, mepacrine. Diaminopyridines, pyrimethamine, quinoline, methanol, mefloquine. Artemisinin, arteether, artemether, artesunate. Sulfones, dapsone, sulfadoxine. Biguanides, proguanil. Very easy classification. If you remember headings, everything will be sounding similar. These antimalarials are bitter, water-soluble crystalline powders that are readily and completely absorbed from the gut. They are actually amphiphilic, that means they will have hydrophilic and hydrophobic, that is lipophilic part also. To make them more absorbable from the gut, they will be formulated to have more water soluble. They will bind avidly to tissue proteins. Avidly means rigorously, greedily. Hence, they will get more concentrated in liver, spleen, kidneys, adrenals, eyes, heart, muscles and lungs. Highest concentration in liver because of their lipophilicity. As I have already told you, it is amphiphilic, lipophilic part. Because of this lipophilic part, they will have 100 times more concentrated in tissues when compared to the concentration in the plasma. So they will have very large T-half of 40 days for CQ, 50 days for HCQ. They are metabolized in liver to water-soluble active metabolites, desethyl CQ, from HCQ to desethyl HCQ as well as desethyl CQ. After getting metabolized, they will get excreted mainly via urine for CQ, and small amounts are excreted via saliva, sweat, breast milk and bile. As they have lipophilic component also, they can easily cross blood-brain barrier, placenta and even found in breast milk. As they are metabolized in liver, obviously they will be excreted via bile and feces. Mainly via feces is HCQ, mainly via urine is CQ. Coming to mechanism of action. Main mechanism of action is light filtration. They will easily cross the cells in the epidermis and they will bind to melanosomes as they have high affinity to melanin, and they will help in light filtration, which will use in treating UV induced cutaneous reactions in LE and PMLE. Same way, melanin is not only present in our skin, it is also present in our retina. They will go and get accumulated more and more in retina. In long run, they will cause retinotoxicity. That is what we call as toxic retinopathy. Next, immunosuppression, as they inhibit toll-like receptors, antigen-antibody complex formation, anti-inflammatory effect by inhibiting chemotaxis and lysosomes. These antimalarials will go and get concentrated into lysosomes also, inhibiting their function. Anti-proliferative by inhibiting DNA and RNA synthesis. Antiviral property. These antimalarials also have antiviral property. When I have just entered my internship, at that time first wave of COVID was going on. At that time exactly this news came that HCQ has antiviral properties which we can use for COVID-19. Then immediately after listening this, me and my friends rushed to medical shop. By that time itself already HCQ was out of stock. Next mechanism of action, inhibits platelet aggregation and reduces lipids. Indications of antimalarials. FDA approved uses are every one of us know malaria. Then rheumatoid arthritis. Coming to skin, it is lupus erythematosus. We'll give HCQ maximum 5 mg per kg per day. Off-label uses are photosensitive diseases like solar urticaria, porphyria cutanea tarda. Lowest dosages we will give here. Remember this word, low dosages for porphyria cutanea tarda. PMLE dermatomyositis. Granulomatous diseases like granuloma annulare, sarcoidosis. Here we will give CQ. Per day maximum how much we can give? 2.3 mg per kg. If it is HCQ, 5 mg. If it is CQ, 2.3 mg. Remember, HCQ has 3 words, more 5 mg per day. CQ has just 2 words, 2 mg per day. Benign lymphocytic infiltrates like Jessner's, lymphocytic infiltrates, lymphocytoma cutis, panniculitis, lupus panniculitis, others like atopic dermatitis, vasculitis, urticarial vasculitis, oral lichen planus, pemphigus foliaceus, follicular mucinosis. These are all off-label uses. Only FDA approved use is LE. Coming to adverse effects, mainly eye, toxic retinopathy. True retinopathy is irreversible. That means once the vision is lost, that's it. No one can bring back the vision. More with CQ. Retinotoxicity is more with CQ than HCQ. Quinacrine is safe. That means it doesn't have any retinotoxicity. Final stage of true retinopathy is bull's eye maculopathy. Rest of all the other adverse effects are reversible. That means if we discontinue the drug, those side effects will resolve on its own. Premaculopathy, which is reversible. At this stage, there is no vision lost yet. Only problem is visual field defects. We have to stop the drug at this stage only, because if we discontinue the drug, it is reversible. It will come to normal. We can save the patient's vision. Corneal deposits. Patient complaints of halos on seeing visible light. These deposits we can find incidentally if we do slit lamp examination also. Loss of accommodation for CQ. Retinopathy is very important. Before starting antimalarials for a long term, we have to definitely send the patient for eye checkup to check already if there is any retinopathy conditions in the patient. If there is a documented retinopathy, it is an absolute contraindication. Patient's vision is in our hands until he goes into this stage, that is true retinopathy stage. Without eye checkup, never start antimalarials for a long run. Same like any relationship, if it goes into irreversible stage, no one can bring back that lost relationship. Whenever it is in our hands, we have to save it. If the patient's vision is in our hand, at any cost, we have to save it. Because once the vision is lost, no one can bring it back to the patient. You will be liable. That's why never neglect your family in the name of career, at least for a few minutes. However the busy you are, try to spend time with your family. Coming to next side effect, GI. Why I am telling this philosophy in between the classes? Because this word irreversible has that much of depth. It is related to patient's vision. Coming to GI side effects like nausea, vomiting, diarrhea, more with CQ. CNS side effects like headache, confusion, seizures, restlessness, toxic psychosis, as these drugs can cross blood-brain barrier also. Hematological, mainly hemolysis only at high dosages and in G6PD deficient patients, not normally seen with CQ, HCQ. Agranulocytosis for CQ, aplastic anemia for quinacrine. Cutaneous adverse effects like yellow discoloration with quinacrine, bluish grey to blackish pigmentation, especially on shin, face and palate. Skin rashes like most commonly morbilliform rash, urticaria, eczema, lichenoid drug eruptions, exfoliative erythroderma, pruritus and xerosis mainly with CQ. If a patient develops skin rash, we have to stop the drug and we may re-challenge the patient with another drug with low dosages. If a patient gets skin rash with CQ, we can start a low dose HCQ by stopping CQ. Rare side effects like ototoxicity, cardiomyopathy, neuromyotoxicity. Because this drug is getting accumulated in various tissues, rarely they can cause these side effects. In cardiomyopathy, they can cause conduction blocks. Coming to contraindications, absolute contraindication is documented retinopathy. We have already seen before starting antimalarials, you will send the patient to eye checkup. There, if any retinopathy found, we have to not start the drug. We have to stop the drug. Even before starting, if while the patient is on antimalarial, if any retinopathy gets documented, we have to stop the drug and save the patient's vision. Hypersensitivity for any drug, it's common. Relative contraindication is pregnancy and lactation, as they can cross placenta and breast milk. Coming to investigations and monitoring, we have to do first baseline eye checkup, slit lamp, fundoscopy, acuity and visual field, CBC, LFT, RFT, every month for 3 months followed by 6 months once. Random or 24-hour urinary porphyrin. Why we are checking porphyrins here? If the patient has porphyria, if we give high doses of antimalarials, it will act as porphyrinogen. It will stimulate more and more production of porphyrin and may lead to acute porphyria attacks. That's why in porphyria patients, we should always start with low dose. Gradually, we have to increase the dose. At low dosages, they eliminate the porphyrin. At high dosages, they will produce porphyrins by stimulating ALA enzyme. Follow up yearly after 5 years. Why until 5 years we are not doing any follow up? Because cumulative toxic dosages are very high, that is 1000 grams for HCQ, 460 grams for CQ. To reach this dosage, it will take minimum 5 to 7 years. That's why after 5 years, we will do yearly checkup, eye checkups. For high risk patients who already have any eye problem or complaining of visual symptoms, we have to do yearly. HCQ and CQ, if we give combinedly, it will lead to more retinal toxicity. That's why as an add-on, you can add quinacrine, which is safe, no retinal toxicity with quinacrine. Never add HCQ with CQ or CQ with HCQ. Remember the channel name. Don't forget to like, share and subscribe. Thank you. Hasta la vista. До свидания.